Good morning. My name is Ana Mascareñas, and I'm the Senior Advisor for Environmental Justice in the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services. On behalf of the Office of Women's Health, we are pleased to welcome you back to the Endocrine Disrupting Chemicals and Women's Health Symposium. Today's talks will focus on successful interventions reducing the impact of endocrine disrupting chemicals. We'll learn some new ways to make a difference in our own lives and in our communities, as well as learn about great work taking place in women's health at the state and federal government level. A few housekeeping notes before we begin. We understand you might not be available to join us live for the entire symposium, and we encourage you to view the agenda and join sessions as you're able. You're welcome to return if you need to exit at any point, and all sessions are being recorded and will be available a few days after the event. Also, the chat box is available for questions to our speakers. We have a full agenda, and we'll do our best to direct questions to the speakers as time permits. And when you do submit a question, we ask that you please note who the question is for, especially during the panel session. Lastly, before the lunch break, we invite you to join the poster session featuring 12 poster presentations. The link and instructions to join will be made available later this morning. Now it's my honor to introduce the Assistant Secretary for Health, Admiral Rachel Levine, to give opening remarks. Admiral Rachel Levine serves as the 17th Assistant Secretary for Health at the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She's working to help our nation overcome the COVID-19 pandemic and build a stronger foundation for a healthier future, one in which every American can attain their full health potential. Admiral Levine has had a storied career, first as physician in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. She then served as Pennsylvania's Physician General and later as Pennsylvania's Secretary of Health, where she addressed COVID-19, the opioid crisis, behavioral health, and other public challenges. I now have the privilege of working under Admiral Levine's leadership to help address the health impacts of climate change and advance environmental justice in communities across our nation. Thank you for joining us this morning, Admiral Levine.
Well, good morning. Thank you for that introduction, Anna, and thank you all for joining us today. In my role as the Assistant Secretary for Health, I oversee a number of very important program offices, which include the Office on Women's Health, the Office on Minority Health, our Office of Infectious Disease, HIV/AIDS Policy, and of course, Anna's office, our Office of Environmental Justice, and others. Each day, we strive to address the diverse health needs of our nation. And our goal is to create a healthy nation with healthy people and healthy communities for all. Achieving health equity requires valuing everyone equally, with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the social determinants of health, and work to eliminate disparities in healthcare. Everything that we do under Secretary Becerra's leadership emphasizes health equity. OASH has a deep commitment to understanding and addressing women's health needs, and we are very pleased to share research, resources, and tools that you can use in regards to your own care, as well as your family's care and our community's health. Yesterday, leading professionals from across the country shared ways to support reproductive, maternal, and child health, reduce breast cancer risk, and minimize the impacts of toxins. Today, you will hear about successes in reducing exposure to endocrine disrupting chemicals and improving women's health at the state and federal government levels. I am really, truly heartened by the progress being made to protect women from the harmful substances that they are exposed to every day. My HHS colleagues and I are committed to tackling toxic exposures of all kinds. Our recently formed Office of Climate Change and Health Equity and its sister Office of Environmental Justice focus on supporting communities that face disproportionate environmental health risks. In traveling across the country, I have seen firsthand the health impact of environmental toxins. Just as seriously, we are all seeing the impact of smoke from Canadian wildfires that continue to carry pollutants across national borders. The Office on Women's Health recently awarded 15 winners in Phase 1 of the HHS Endocrine Disrupting Chemicals Innovator Award competition. This competition was developed to identify gaps in knowledge and innovative solutions to improve women's health by reducing exposure to chemicals. The award competition is only one part of our multi-pronged approach to promote innovative and community-led solutions and to advance health equity for all. We will welcome several winners from phase one of this competition during a panel this afternoon, where they will describe how their programs have benefited their communities. We hope you can join us for that session. As we continue our work, I would like to leave you with this. Do not undervalue the impact of simple and small changes that we all can make. Keep canned or plastic packaged food away from heat sources, such as summer sun or microwave. Dust and vacuum your home to minimize buildup of harmful particles. In my work on national policy at HHS and as policy in Pennsylvania as the Secretary of Health, I have seen many times about small improvements, that small actions can improve your own health and your family's health, as well as the health of your community. Now, today it is my pleasure to introduce our keynote speaker, who comes to us with extensive knowledge and experience. Dr. Linda Giudice is a distinguished professor of obstetrics, gynecology, and reproductive sciences at the University of California, San Francisco. She is a biochemist and reproductive endocrinologist, specializing in endometriosis, adenomyosis, ovulatory disorders, and infertility. Her research focuses on multi-omics approaches to elucidate the function and dysfunction of human endometrium in health and disease and environmental impacts on reproductive health. She has mentored countless students, fellows, and faculty, authored more than 325 peer-reviewed publications, and is co-editor of 7 textbooks on women's health, endocrinology, environmental health, the endometrium, and endometriosis. She has received numerous awards acknowledging her contributions to science, medicine, and mentoring. So please join me in giving Dr. Giudice a warm welcome. Thank you.
So thank you so much for your kind invitation and introduction. I'm trying to advance my slides here. There we go. Thank you. So today I will be speaking at this amazing conference, and I'm so grateful to be invited with so many experts and those who have much interest in this topic and also in making a difference as we move forward. I have no disclosures. And so you may wonder, why am I giving this presentation? Well, as a physician in reproductive medicine, but also as a concerned citizen of the world. And it first began for me in 2002 when a colleague asked if I thought that infertility and miscarriage might have some connection to growing up in Superfund sites or near Superfund sites. And one of these is Love Canal, one among many. And many of the pictures shown here you heard about yesterday. So when we think about interventions, first we need to understand the EDC exposures and who is at risk for impaired health outcomes, understand models of evidence of harm and challenges to getting evidence about interventions to ameliorate EDC impacts. Also today, I hope that we can all share and learn and discuss evidence showing interventions successfully ameliorate the impact of EDCs. So in terms of exposures to EDCs, I think you're all quite aware, there are general population exposures over which individuals have control, and there are some things that we don't have control of, or at least not directly. And these are shown here, and these were discussed in quite a bit of detail yesterday. And there are also occupational exposures among agricultural workers, cosmetologists, technicians, agricultural workers, as mentioned, healthcare workers, and many other professions. And it was shown several years ago that every person in the U.S. has contaminants and that mixtures are the rule. And as reported in one report, that babies are born polluted, which is a very sobering thought. So who is at risk? Well, everybody is at risk, but some more than others. The most vulnerable are the developing fetus, children, pregnant persons, the elderly, those with chronic diseases, marginalized populations, lower sociodemographic status, and workers in hazardous jobs. The scientific evidence that links endocrine disruptor chemical exposures and poor health outcomes, most of these have been described yesterday. We heard about animal and in vitro cell models that really underscore the mechanisms and the connections with much of the epidemiologic data. I'd like today to also introduce the navigation guide developed by Tracy Woodruff at my institution, University of California, San Francisco. Also, as we think more about mixtures, taking big data and modeling and informatics in terms of understanding mixtures and their impacts, and also job exposure matrices. And this is important because as we think about interventions, we need to know what the exposures are. And of course, systematic reviews, scoping reviews, meta-analyses, and wildlife observations. So how to bridge clinical and environmental health? I think you're all familiar with the Cochrane collaboration that organizes research findings and facilitates evidence-based interventions involving health professionals, patients, and policymakers. And GRADE, which is a systematic approach to rate the certainty of evidence in systematic reviews and other evidence syntheses. So this is an example of the navigation guide. A specific study question is proposed, the evidence is selected from the literature, and then it's rated for quality and strength with regard to evidence in humans and also evidence in non-human models. And then the grade of the strength of the recommendation is derived. So this is an integration of Cochrane and GRADE premises into some clinical outcomes. And this is just one example of PFOAs and intrauterine growth restriction, where the strength of the evidence in non-human systems was sufficient and in human systems sufficient, and the conclusion was that human exposure to PFOAs is known to be toxic to human reproduction and development based on sufficient evidence of decreased fetal growth in both human and non-human mammalian species. So the navigation guide, Cochrane and GRADE have been acclaimed as exemplary approaches for transparency, rigor, and reproducibility by the National Academy of Medicine. This process is incredible. It's also very labor and time intensive, and it's expensive. And initially it began as a one-by-one approach, but that is now being modified. So I'd like to now go to some of the challenges to intervention strategies and take pregnancy as a case study. We know that humans are exposed to multiple chemicals of different classes with similar or different signaling mechanisms that can lead to synergistic, additive, antagonistic, or no effect on physiologic outcomes. So challenges in risk assessment and data interpretation and quality evidence for intervention strategies some of these are shown here. So what are we going to sample to look at? In pregnancy, there are many things. The placenta, cord blood, amniotic fluid. Most studies sample at a single gestational time point, but pregnancy physiology changes over gestation. And often there is inconsistent attention to fetal organ-specific differences in susceptibility windows, that fetal sex can modulate EDC effects, and there can be founders. And of course, the word that we'll be hearing a lot about today is mixtures. And some cohorts now follow the children longitudinally, and this is important if we institute an intervention during pregnancy. What are the long-term data for that for the children? Less focus has been made on correlations and subsequent maternal morbidities, and this is important because if we initiate an intervention, we want to see what effect there may be, positive or negative, on comorbidities. So I'd like to turn to mixture risk assessment. Maternal exposures to the same chemical class or same mechanism of action has been shown to, on a one-by-one basis for a chemical, to have weak associations with low birth weight. However, as a class, these associations are strengthened. This is a very interesting study and there are others, taking advantage of statistical modeling of mixtures of different EDC classes. So in this study, 50 chemicals with divergent characteristics and similar and dissimilar modes of action in maternal and fetal samples were assessed. And then the authors applied statistical modeling and including an analysis called principal component analysis, which is a methodology to take very complex data and high dimensional data and reduce the dimensionality of it so that we can figure out what's going on. And what they found was that this particular principal component, number 1, was associated with lower sociodemographic status and also BMI greater than 25. And this is among all of these chemicals of different classes and modes of action. Now, challenges currently are that regulatory guidelines of allowable concentrations of environmental EDCs were developed on a chemical by chemical basis. I don't think that should limit our ability to mine the data and understand about mixtures, and especially when we're looking at interventions. What are the endpoints? If it's one chemical, is that enough to measure? Because there are many chemicals present. And statistical modeling, in turn, needs standardization as several inputs with increased rigor, including biomonitoring approaches. With regard to job exposures, about 20 years ago, there was a job exposure matrix that was developed in the UK in an effort to understand occupational exposures to EDCs and risk of hypospadias and cryptorchidism in children. And then subsequently it was updated. And in this system, 353 job classifications were identified. Exposure risk scores were derived, 0 being no risk, and then a gradient from 0 to 9, with 9 the higher exposure levels, and scoring chemical categories and subcategories and occupational settings. And the result was 10 chemical groups and job exposure matrices, and this is an example of 5 different job titles. Senior government officials, some of whom may be in the room today. The exposure score was assumed to be 0. Electrical workers got a 1. Glass ceramic makers and decorators exposed to organic solvents and metals. Beauticians and related occupations to more complex chemical groups, and chemical processors were at high risk. Now, it's always challenging to do this type of assessment of exposures because there can be different exposures over time. Tasks may change from one year to the next. And also biomonitoring data need to be available to make these assessments. And just to give you an example of how occupational exposures to EDCs have been assessed with regard to pregnancy as the model today, but this is applicable to all areas of women's health. This was a study, a large study of over 100,000 mother-child pairs in 13 European cohorts for the birth years 94 to 2011. And the maternal job titles were linked with exposures to 10 EDC groups assigned in a job matrix, and the birth outcomes were correlated with exposure categories, and a meta-analysis of the cohort-specific estimates was conducted. And the results show 11% of pregnant persons were exposed to EDCs at work in pregnancy based on job title. The exposure to one or more was associated with increased risk of term low birth weight, and the risk increased with exposures to increasing numbers of EDC groups, as shown here. And the highest risk groups were agricultural workers, house cleaners, hairdressers, and medical assistants. And so this is important when we are thinking about interventions to know what patients are exposed to. What is their occupation? What are their hobbies? In this study, data were consistent across all 13 European birth cohorts, which I think is quite amazing. And the conclusion was that employment during pregnancy in occupations classified as possibly or probably exposed to EDCs was associated with an increased risk of term low birth weight. So the conclusion is not to work when pregnant, but rather to make the environment for pregnant persons to be able to work in a safe environment. Now, intervention studies to ameliorate EDC effects are a few. There aren't a lot. I'll show one with regard to an animal model where epigenetic modifiers rescued the phenotype. In addition, human studies looking at individual levels of how things can be how interventions can impact levels of particular EDCs, and that's at the individual level. But there are other ways also to ameliorate EDC effects, and those are policy changes and also entrepreneurial opportunities, as we'll see. Also education. What do we know? What does the lay public know? And how enthusiastic are people about learning about exposures? And also advocacy, which is a key piece to intervention studies, especially at the level beyond the individual. So what is the evidence that interventions will impact EDC levels? And what is the evidence that interventions will impact and improve health? So this is a complicated model. It's the agouti mouse. Where you see these two mice, they are genetically identical, but they look different. One is brown and the other is yellow, and they are different sizes. And the normal healthy mice, the so-called agouti gene is methylated and is off. So usually DNA methylation will shut off gene expression, but not always. And the yellow obese sisters, the agouti gene is unmethylated and on. And the agouti gene product binds to a receptor that blocks black pigment and is involved in feeding behavior and weight set point. So when the pregnant mother was fed regular mouse food, the offspring mainly looked like the mother and were in poorer health. However, when the pregnant mother was fed supplements with compounds rich in methyl groups, donor groups, there was a shift, with the offspring being predominantly brown and in good health. And to add insult to injury, in this experimental design, the pregnant dams were given bisphenol A, and it was noted here that there was a higher ratio of yellow obese progeny than expected, and there was global DNA hypomethylation, and 30% of the agouti gene DNA methylation sites had decreased methylation. However, with some environmental protection, that is the administration in this case of folic acid in particular, it rescued the phenotype. So there was increased DNA methylation and a normal ratio of pups. So this is an extraordinary study. It's complicated. It has the genetic input and may or may not be translatable to humans. So I'd like to show you some of the interventional studies in humans, starting off with diet, personal care products, and also household products. So this is a study showing dietary interventions in children can reduce EDC exposures. 23 children were monitored for metabolites before and after an organic diet. So here's the conventional, the organic diet, and the conventional diet. And levels of urinary metabolites for chlorpyrifos and malathion were reduced to almost non-detectable levels. And again, on reintroduction of the conventional diet, the levels went up. So this, I think, is a pretty good demonstration of how diet can affect urinary metabolite levels. The Hermosa intervention study was done several years ago in Salinas Valley with 100 Latina girls in a community-based participatory research study. And it was, the goals of it were to determine if using personal care products for only 3 days would change urinary levels of certain compounds, as you can see here. And patients were given, or participants were given over-the-counter products without triclosan, BP3 that we heard about yesterday, parabens, and phthalates. And what you can see, and these are the actual data, but you can see perhaps even more clearly on the graph that some participants did respond, not all, but some did respond with a pretty significant reduction of the levels of some of these compounds. And I think the study demonstrates that the techniques available to consumers, such as choosing personal care products that are labeled to be free of phthalates, parabens, triclosan, and BP3, can reduce personal exposure to the constituent endocrine disrupting chemicals. I think it's also important to know that one size does not fit all, so not everybody responded the same way. And human studies are often compounded by these just personal, genetic, or environmental differences. Recently, there were two committees in FIGO, the International Federation of Gynecology and Obstetrics, that have worked together. One is the Committee on Impact of Pregnancy on Long-Term Health and Climate Change, and the committee that I was chair of for 3 years, the Climate Change and Toxic Environmental Exposure Committee. We worked together, and the lead author, Dr. Corbett, and the group here and both committees set out in a semi-structured review. And the objective was to analyze evidence of nutritional interventions to reduce the negative effects of EDCs on reproductive, perinatal, and obstetrical outcomes. That's a very aspirational goal. And you'll see why in just a moment. The search strategy was pretty classic, searching through a variety of databases. And the selection criteria included experimental studies on human populations. The data were collected from eligible studies, and the risk of bias was completed using the Cochrane Risk of Bias tool and the Robbins I tool. Now, the characteristics of the studies, you can see they started out with 15,000 studies, and by the time they looked at inclusion criteria and replicate publications, etc., they came down to 16 for analysis. You can see that the study size, the number of participants, was quite varied. 3 included pregnant participants, 6 young healthy participants, 2 families, 2 of the studies included families. 2 examined interventions in only school-going children, and 4 included mixed gender populations, with a focus on diabetes and cardiac atheromatous disease, and men and women aged over 60. There were 7 randomized controlled trials, 3 randomized controlled crossover trials, and 6 non-randomized experimental trials. And I'm going to show you just a few. These are the 3 of the 6 RCTs. In the first one, this was an N of 75 participants. The intervention group was fresh soup versus canned soup, which was the control, and to look at levels of urinary BPA, bisphenol A. And you can see that the intervention group had a level of 1.1 micrograms per liter, whereas the control group, eating canned soup, had a significantly higher level. Another study looked at the effect of canned versus glass containers for drinking beverages on the urinary BPA levels. And in this group, this was a group over 60, 120 people, they also looked at a health outcome of of blood pressure. There was 1 week of intervention, 1 week of washout. So this is a randomized double-blind crossover trial. And here, the mean urinary BPA levels at the end were in the intervention group, 1.13, in the control group, higher. However, there were no changes on blood pressure. And again, this is a very limited intervention in terms of length of time. Here's another study that looked at the impact of lifestyle interventions, education, BPA-free Tupperware and water bottles, cosmetics, and hygiene, feminine hygiene products were provided. Organic foods packaged in BPA-free glass and cardboard containers versus controls. And also everyone got weekly education on bisphenol A. This was a 3-week trial. And what you can see is that there was a significant treatment by time interventional effect on BPA levels, so that by 3 weeks, the intervention decreased the mean urinary BPA by 0.71 nanograms per mil versus controls who had an increase. These were statistically significant. Whether they are significant from a clinical or health perspective is not totally clear, but still an interesting and valuable study. Putting all of the studies together that were looked at, the evidence supports that organic food consumption and avoiding plastics and canned foods and beverages reduce dietary exposures to EDCs. And I didn't show you all the data, but these are some of the conclusions. No fast foods, iodine supplementation, vegetarian diet, fatty fish diet, altering personal care products, removing dust, are all supported by evidence to lower EDCs, and in some of the cases, they looked at more than one EDC. The caveats are that there are disparities in access to and affordability of organic foods and different kinds of containers and bottles. Most studies are still doing one at a time, EDCs. So the question is, for example, if BPA is decreased and phthalates are not, what might be the consequences from a health perspective where people are exposed to mixtures and not one EDC at a time? And so far, there is rare evidence that reductions of EDCs lead directly to health improvement in some of these randomized or even non-randomized trials. But I think some of the studies described yesterday are very promising, and we're looking forward to seeing those results. Now, also in 2022, another group in Korea, South Korea, did a scoping review. And their question essentially was looking at interventions on reducing exposures to EDCs in the human health context. And so these are the study inclusion criteria. The exclusion criteria, they did not look at cost effectiveness. They were sure that people who related to the investigators were not participants, so they did their due diligence. And you'll note that about 2/3 of the studies were published between 2011 and 2020. And here we have 46% that were published in just 1 year. So hopefully this means that studies are increasing. And it was pretty evenly distributed across the globe. Here, much using similar methodology as the FIGO study, they started with a smaller number, 1,298, and they ended up with 13 studies. So I'm going to review the salient results of this scoping review. About 50% were single-arm studies and no controls. So that already brings up issues of, you always need a control group when performing studies like this. Most interventions resulted in lower EDC levels in blood and or urine, and some overlapped with the Corbett review that we just saw. This is very interesting that authors noticed that compliance was challenging. For example, participants didn't want to change their diet, even with EDCs demonstrated to be lower with interventions. And we'll get into that in just a little bit. One study revealed decreased urinary BPA levels and lower dysmenorrhea scores with 6 months of intervention, but there was no control group. And another study revealed red Korean ginseng resulted in decreased vasomotor symptoms, uterine spotting, and dysmenorrhea, but again, there was no control group. So I think there's actually quite a bit of room for pursuing some of these interventional studies. The overall conclusions are that most well-designed trials show benefit of lowering EDC levels with interventions. And these are absolutely essential to inform if interventions achieve their goals of significantly reducing levels in fluids and tissues. And also, I think we need to connect this at some point to improving demonstration of improving clinical outcomes. The question of patient awareness for buy-in of changing behavior arises that I think we need to think about. And the question also arises if prospective interventional evidence is required before recommending some of these therapies. Do we have to wait for the evidence? Or, since most of these have low side effect profiles and other benefits, can they be recommended based on existing observational data alone? So, going beyond the individual, I want to just touch briefly on policy changes. There is hope. Actions can reduce exposures, but policy changes are needed. For instance, removing lead from gasoline resulted in lowered blood levels at the population level over time. However, if you go before the 1970s, when this was instituted, there was about 20 years of advocacy on the part of the American Association of Pediatrics with regard to the toxicity and neurodevelopmental effects in children. So advocacy is also a key piece of this. And in Scotland, the smoking public ban reduced preterm birth rates. In California, someone mentioned yesterday about PBDEs. California had a law in which to minimize house fires due to smoking and people falling asleep on the couch and having a fire, that most of the foam and furniture contained high levels of PBDEs. And this is a study by Tracy Woodruff's group that showed that in Northern and Central California, pregnant persons have absolutely the highest levels compared to cohorts, the U.S. NHANES cohort, as the Salina Valley cohort, and also in Madrid, Spain. So actions do matter. Finally, PBDEs were banned in California in 2006, And Amizota and colleagues did this study and demonstrated that between 2007, so a year after the policy went into effect, excuse me, through 2012, there was a 65% decrease in PBD levels in California pregnant persons. So that's, I think, quite a remarkable demonstration. And there are likely other approaches as well. So green chemistry, this is on the entrepreneurial side, has been proposed to replace hazardous chemicals, processes, and make products with safer alternatives. And there was a lot of hope put into BPA alternatives, such as bisphenol S and bisphenol F. And these were then analyzed in a few studies, and I'm sure there are more. Unfortunately, these did not seem to be safer because, at least in these two studies, there was even more hormonal disruption. So how do we identify those at risk of harm for EDCs and counsel them to mitigate or minimize their risks? A few years ago, the American College of OBGYN asked its 50,000 members to participate in a survey. There was a relatively low response rate, but these are the data. The question was, do healthcare professionals do an environmental history? So 78% of the obstetricians surveyed said that they thought they could probably reduce patient exposures, yet less than 25% reported taking an environmental health history. So they were asked, well, what do you ask about? And if you don't ask about environmental chemicals, why not? So almost everybody asks about diet, alcohol, and smoking, but less than 20% asked about personal care products, home cleaning products, and other products in use. And the reasons were bigger fish to fry. We have 10 minutes with a patient. We need to get to the point. Some response was, we won't know what to say. And others felt that will be opening Pandora's box. So that's basically a combination of these two. And so some interventions are to put brochures to patients on prenatal care entry or making available in a waiting room or exam room, and staff providing patients with information on nutritional counseling or other germane health education regarding avoidance of toxic chemicals. And these are, of course, applicable not only to pregnant persons, but also to all patients, and I would hope would be extended to obstetrics, gynecology, and other settings for women's health care, including adolescents. And taking an environmental health history, some institutions are now instituting smart sets in the electronic health record. So you can click, 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 click what the patient has been exposed to. Of course, you need to read it and interpret it and discuss it. So what do we mean by taking an exposure history? Here are two examples online, readily available, one from our Program for Reproductive Health and the Environment at UCSF, and the other at the EDC, at the CDC. So when counseling patients about their exposures, we need to understand that the patient risk is a function of toxicity, dose, frequency, duration, and timing of exposures, especially in vulnerable developmental windows and individual patient vulnerability, including underlying health conditions and socio-demographic status and exposure routes. Also, we should identify patients with hazardous occupations or hobbies. Persons with occupational or recreational toxic exposure are at higher risk of adverse reproductive outcomes. We saw that in the job exposure matrix. And I think it's important to note that the legal workplace limits are not created to protect pregnant persons, and so specifically, and so it's important that we provide the education for protection. And persons exposed to chemicals via hobbies may have lower exposures versus those working in similar industries, for example, jewelry making, but they may have less safety training. So education is extremely important. So what do we know? What do individuals know about EDCs? And this is an interesting set of studies, just hearkening back to the observation by the Korean scoping review that some patients were really reluctant to change their diet. And so a few studies have assessed public awareness. These qualitative studies show knowledge and awareness of EDCs among the lay public is relatively low. There was a study that looked at perceptions about exposures to EDCs and decline in male fertility. And there were some controversial links, and this study noted that basically just talking about it and being aware of it was received positively, even though there was scientific uncertainty. And it sort of debunked the idea, at least in this population, that EDCs elicit negative psychological or uncertainty about the data about them, elicit negative psychological effects. I think we need a larger number of studies to address this pretty important issue. Another study looked at pregnant persons. The conclusion from this cohort was that the majority did not believe that they were particularly susceptible to exposures, but believed exposures to EDCs were extremely dangerous. So what they learned about EDCs was that they're dangerous, but not me. I'm okay. And then a more recent study of the general public conducted in Belfast in Ireland had a broad range of ages in focus groups. And this study demonstrated generally little awareness, a knowledge of and awareness about EDCs, their sources and associated health effects. And while unaware of possible individual mitigation strategies, the majority expressed that they felt that the government was responsible to mitigate the effects. So how can healthcare professionals promote successful intervention strategies? As we mentioned, taking an exposure history and providing patients with resources and referrals. Need to get information to patients about known effects and reducing and eliminating exposures to EDCs with extrapolation to preventing adverse health impacts. Working with community leaders and policy officials to expand the network of information without being topic experts themselves. It's always a little intimidating, I think, to talk about EDCs, long names, chemical structures that not everybody is familiar with. Well, one doesn't have to be totally familiar with all those details, but certainly can be an advocate and educator. And government and academic resources and referrals about specific environmental exposures with regard to women's health and reproduction are available. And here are some resources, and there are others. We heard about some yesterday. Dr. Gore, who gave a wonderful talk yesterday, was really quite a pioneer through the Endocrine Society here in the US. And also an introduction to EDCs and how to talk to policymakers. That's a very important thing. These are some brochures from our program. ACOG has a newly issued update committee opinion on environment and climate impacts on women's health. And ASRM, the International Federation of Fertility Societies, and FIGO are all very active, as is the WHO. So there are resources out there. Now, just one example this is from our FIGO committee. This is an infographic. It's toxic chemicals in pregnancy. It could be pre-pregnancy. It could be without pregnancy. But basically, things to do for a healthier life. Avoid eating and drinking or storing food in plastic. Don't microwave in plastic, cook with cast iron or stainless steel, not nonstick pans, avoiding fish in high mercury or PCBs, eat fresh organic foods or clean off pesticides if one has access to these, limit cosmetics or at least know what you're using, Avoid dry cleaning or stain-treated clothing. Use a wet mop to get rid of dust, which contains a lot of EDCs. Avoid consumer products with flame retardants, such as PBDEs. And a very simple thing, remove shoes before entering your home. So policy efforts, we need transparency of data. We need a population that's educated in risks associated with specific exposures. And we need an informed governing body and industry partners with the common will to change policy in the interest of the public health. Disparities in exposure risks among vulnerable populations mandate the inclusion of environmental justice in policies to improve the public health. And across the pond in Europe, there's REACH, which is a group that basically puts the onus on the manufacturer to demonstrate safety, whereas in the US, we fall somewhat short of doing that. So we still have some more work to do. So in conclusion, scientific and epidemiologic data reveal mechanisms and associations of exposures to EDCs negatively impacting women's health and developmental processes and outcomes. While strategies to control EDC exposures may show lower body burdens, whether there is a direct improvement of epidemiologically associated disorders is largely unproven, but I would argue should not derail preventive strategies, especially with the precautionary principle. While EDCs are ubiquitous, highest risk is among vulnerable populations who should be included in all intervention mitigation strategies. And we need to incorporate environmental and occupational health in professional education. And I believe that healthcare professionals, scientists, citizens can play a major role in raising awareness among colleagues, trainees, patients, the general public, communities, and government leaders, key to improving human health. So environmental toxicants are tilting the risk balance unfavorably for women's health outcomes. This is an environmental issue, a public health issue, an occupational health issue, a social justice issue, a human rights issue, an economic issue, a political issue, and a gender issue. And I want to thank you for your attention.
Thank you so much, Dr. Giudice, for your presentation. I really appreciate it, and I'm sure the audience appreciated all of the information that you provided us, products to avoid, policy steps that we can take for advocating within our respective communities, as well as how we can reduce exposure among members of the pregnant population, and what we can do to just improve our fertility risks. Or minimize our risks during fertility. We do have questions in the chat. And so the first question, Dr. Giudice, is the person asks, can you address any efforts made to overcome apathy towards EDCs? This person says that they've heard people say things like, well, everything can cause cancer, so what's the point? The intervention numbers that you presented are amazing, and she's wondering, or they, I'm sorry, are wondering what can be done to encourage the adoption of alternate behaviors, or whether the people enrolled were already self-motivated to make changes.
That's a very good question. Thank you. It looks like from the Korean data that, or at least the scoping review, while some participants may have been motivated to participate, they may not have been motivated to actually change behavior. And this is where I think community base and healthcare leaders and physicians and nurses and other healthcare professionals who have direct patient contact can be very, very influential. Overcoming apathy, I think if patients and the general public understands the harm that's associated with EDCs and that regulations need to be strengthened, I would hope that they would not be apathetic. Sometimes the news is overwhelming. If you get too much information, or if it's so negative, I think, a natural reflex to just turn off. But I think we have a responsibility, and we have a lot of resources to do this. I think a grassroots level is important. And it goes beyond pregnancy. It goes to all of women's health. It goes to men's health as well. So I hope I answered your question.
Thank you. The next question is, why is it that conventional recommendations on environmental chemicals cannot readily protect humans in the low dose range?
So environmental chemicals are, as you know, various classes and mechanisms of action. They can, at very low doses, still bind to the steroid hormone receptors and interrupt development. So, there was an old adage, the dose makes the poison. That's really not so. Low doses can have adverse health effects. They may be different than higher doses, but still one needs to be very careful. When we think about alcohol in pregnancy, for instance, the ACOG recommendations are there is no safe limit, so 0. So that, I think, is a testimony to the fact that even low doses of endocrine disrupting chemicals can indeed cause harm.
Thank you. In the introduction of legislation, how do we get society to accept such changes, especially in terms of a public smoking ban that was enacted in Scotland?
Oh, I'm sorry, say that again.
I think their question is, how do we get society to accept changes around EDC reduction or exposure as like a public health, like a large public health good or policy? And they example of a public smoking ban that was enacted in Scotland. So how do we get the public, in our case, the US, to accept something like that?
Sure. So there are professional organizations, as you know, like the American College of OBGYN or the American Congress, that has a presence in Washington. They're able to talk to legislators at the federal level. And there are essentially chapters of ACOG all over the country, local chapters, or districts. And so advocacy at that level in terms of influencing legislators, I think, is really important. How to get that advocacy going is a challenge. And professional organizations, I think, over the last 15 years or so, have been, the Endocrine Society, for instance, has been a huge advocate. And so having those who have, well, first of all, constituents talking to their representatives, and professionals in these professional organizations, I think, are two key ingredients in moving things so that we, 10 years from now, when there's another meeting like this, or maybe 5 years from now, we don't want to be talking about the same thing. We really want to push the needle on this. And that's going to take education at all levels and advocacy.
Agreed. If low-dose EDC mixtures play a role in the development of many diseases in humans, but traditional approaches to chemicals and innovative scientific approaches do not work, what can we do?
That is the big question. But I think, again, through the mitigation strategies at the individual level, and at the health policy level, those have to merge. It's unfair to put it all on an individual or an individual community. Of course, those measures at the personal level or community level are very important. But if there are exposures beyond one's control, then one needs to be able to go to the source of those exposures, and that's where health policy becomes very important. So it's interesting that in the survey of the patients in Ireland who said, yes, these are bad things, but we don't know what to do, but it's the government that should do it. So one needs the political will as well as collaboration. And I think we also have to engage industry partners because regulations, and this is not a Pollyanna approach. I mean, I think everyone's aware that some regulations are costly and profit is an important piece of commercial life. But there do need to be regulations that parallel, and I think we need to also engage our industry partners in these discussions. It's not just unilateral.
Okay. Another question. As obstetricians indicate that they are the physicians best positioned to reduce exposure, what about those populations who don't see that sort of specialist? For instance, women who are not pregnant, or I would even extend this to males. Should such screening and intervention happen for more of the larger population of women, and who would be doing that type of screening? Pediatricians, gynecologists, urologists?
Absolutely. It's the primary care physicians, the pediatricians, the internal medicine doctors, and it's also, and general gynecologists, urogynecologists, urologists, absolutely. This is not an issue that is specific for pregnancy. This is an issue that is for the health of all citizens.
What comprehensive precautionary measures can be adopted to effectively minimize the potential risk of endocrine disrupting chemicals associated with excessive use of cosmetic products, lubricants during sex, perfume, shaving creams, hair removal creams, and other similar products?
So I think someone said this yesterday, and I'll repeat it, read the labels. And there are websites, Environmental Working Group, Safe Cosmetics. There are places to go to see if your particular shampoo or deodorant or other cosmetics have either toxic effects, reproductive toxic effects, carcinogenic effects. And so these things are listed and they're scored. And then one can make a decision whether this is what is it time for a change.
So this question kind of piggybacks on the question that you just responded to. How do we change the formulation of such products, especially as it relates to cosmetics?
So again, going to these resources is really important. Another piece of this is going and having a voice among the manufacturers. There was a movement in Europe several years ago, I'm not sure it actually came to fruition, where a cosmetic company decided it was going to take out or reduce certain EDCs. And when I've made inquiries, my colleagues are not aware that this actually happened. But the fact that, it's not just that the cosmetics are there, someone had to make them. And so, again, engaging industry partners is important. I think some of the data presented yesterday on breast cancer are, of course, very disturbing. And again, advocacy groups and working in communities, and eventually, getting to the source, I think, is an important piece of this. But it's not just one solution. It's an integrated effort at the individual level, at the community level, at the legislative level, and at the commercial level.
Thank you. We have time for a few more questions. I'm going to try to scroll through because we have talked about what we can do at a policy level as consumers to try to avoid our exposure or limit our exposure. You talked about the resources. Someone asked, they just visited the ACOG site, and under their advocacy page, I don't know if you can speak to this, Dr. Giudice, EDCs is neither a priority or listed as a focus. Why is this, and what can we do to change it?
So Dr. Jean Conry, who was president of ACOG in 2013, and is current president of the FIGO, has been a major player in this. ACOG has, all large organizations have somewhat of a bureaucratic process to get things through committees so that the language is right and the data and the evidence is there or are there. And so the committee opinion that has come out is just last year is a really important one, and it embraces EDCs as well as climate change. Why it's not listed there, I don't know. But I think that patients can talk to their gynecologists and obstetricians or primary care doctors, but probably more for ACOG, the OBGYNs, at the district level, and ask them in the office, how come you guys this isn't a priority? And many of those healthcare providers are active members of the districts of ACOG across the country. And I would hope that ACOG would have this. They've come out with a committee opinion. It seems like, their heart's in the right place. Transitioning that to improving or putting on the advocacy agenda, there may be competing items on that agenda as well, I would suspect.
Okay. This is kind of a, research-related question. They ask, taurine has been found to help detoxify some EDCs via sulfonation pathways. Do you have any articles to cite? And they provide a link to an article that appeared in Toxin Reviews. Benzoapyrene-induced reproductive toxicity was abated in rats co-treated with taurine. Do you have any articles, Dr. Giudice, that you could reference or recommend that support detoxification profiles?
That's a really good question. I think that's the sort of the holy grail. One is avoidance of exposure and mitigating exposures, and the other is the environmental rescue, if you will, by some kind of methyl donor or taurine or some other approach. I do not know the details of that. It may be, and I don't know if Dr. Gore is here, or perhaps someone else in the audience may have more information.
Thank you. That's going to conclude with Dr. Giudice on successful interventions to ameliorate the impact of EDCs. Again, thank you so much, Dr. Giudice, and thank you to everyone who participated in the discussion. We will now be transitioning to our panel presentation on advancing health equity. I would like to introduce first myself. I am Lieutenant Abiyomi Walker. I'm your moderator for these two sessions. First is Dr. Tamara James Todd. She is an environmental reproductive epidemiologist researching the role of consumer product chemicals on women's health across the reproductive life course. She directs the Environmental Reproductive Justice Lab, which seeks to investigate and improve adverse environmental exposure and reproductive health disparities. Her work particularly focuses on the importance of pregnancy as a sensitive window of consumer product chemical exposures, including hair products and other personal care products. Dr. James Todd is the principal investigator of multiple NIEHS-funded R01 grants, focusing on endocrine disrupting chemicals and adverse maternal cardiometabolic health outcomes during pregnancy, postpartum, and midlife in the ERGO study and Project Viva. Dr. James Todd serves as the principal investigator for the Community Engagement Core of the MemCare P42 Superfund Research Center. In addition, she conducts interventions to improve environmental health literacy, both in the lay community as well as among healthcare professionals. Dr. James Todd is also the Deputy Director of the Harvard Chan NIEHS P30 Center, where she launched the Environmental Justice Bootcamp in collaboration with 2 other NIEHS-funded P30 centers. She has been awarded for her research in women's health by receiving the Estrelita and Yusuf Karsh Visiting Professorship in Women's Health and the Alice Hamilton Award. She has had the honor of serving on the EPA's Scientific Advisory Board for the Chemical Assessment Advisory Committee, as well as 2 National Academies of Sciences, Engineering, and Medicine committees, and the March of Dimes Environmental Justice Working Group. Our second presentation will be Ms. Tanya Charmaine Lane. She is a cosmetic chemist specializing in natural hair care and the creator of curlychemistry.com and Curly Chemistry YouTube channel, which has over 10 million views. Tanya was born in New Jersey and currently resides in North Carolina, where she earned her master's degree in chemistry from North Carolina Central University. With 7 years in personal care industries, Tanya uses her experience, knowledge, and love for hair care to teach and provide the tools needed for women and men to get results with their hair care regimens and understand cosmetic ingredients based on their hair needs so that they can save time and money. Thank you.
Thank you so much for this invitation to be here. I'm really thrilled that this conference is occurring. I think it's quite timely that we continue to have these discussions, and as the previous keynote mentioned, that we continue to really push the way forward around advocacy, around research efforts, and around making change. So today I'm tasked with speaking with you all about disparities around health equity issues, and specifically chronic disease. And I could spend a lot of time talking about that, but I do have limited time with you all today. So while certainly I think you're learning from having attended this conference that endocrine disrupting chemicals are associated with many of the top leading causes of death, for example, as mentioned, even in the previous talk, there's associations with cancer, diabetes. Today, I'm going to talk to you about the association between endocrine disrupting chemicals and heart disease, which is the leading cause of death here in the United States. And so when you're thinking about health across the life course, there are many examples of cardiovascular disease risk factors that emerge at each time point across the life course that can be indicative of an increased risk of later life cardiovascular disease. So whether you're talking about intrauterine growth restriction or being the offspring of a pregnancy that was complicated by gestational diabetes or GDM or preeclampsia, and then kind of moving into infancy, rapid catch-up growth, for example, is associated with later life cardiovascular disease risk, earlier onset of menarche or obesity that could start in childhood. And then there are factors that kind of occur across the reproductive life course, but that are not necessarily completely connected to the reproductive period. So the emergence of conditions like hypertension or diabetes or polycystic ovarian syndrome or PCOS. Also, having a pregnancy loss or complication for the individual who is pregnant is associated with an increased risk of cardiovascular disease. And then earlier onset of menopause or having more severe menopausal symptoms such as hot flashes are also associated with cardiovascular disease risk. So when you're thinking about this, what's interesting, and again today, because I primarily focus on reproductive health and thinking about pregnancy as a sensitive window of exposure for later life cardiovascular disease risk, the examples I will pull from today are really going to come from pregnancy. But it's worth noting that endocrine disrupting chemicals can impact health and these particular outcomes across the life course and have real impact on heart disease risk and development. So in the context of disparities, it's worth noting that cardiovascular disease risk, I'm showing you here the prevalence of hypertension by sex and race ethnicity. They do vary by race ethnicity, with non-Hispanic Black individuals having a much higher prevalence. And I'm going to walk you through a number of established or known disparities as it relates to cardiovascular related risk factors, just to kind of ensure that we're all on the same page. So again, kind of starting earlier on in life, if you're thinking about something like earlier age at menarche, which what I'm showing here is older data, but even with this decrease in age at menarche that's happening across the board, we do still see this much higher kind of prevalence of reaching menarche at an earlier age for individuals who are non-Hispanic Black compared to non-Hispanic white individuals. And here, what I'm showing you is data from the pediatric network, where by age 12, about 62% of Black girls compared to 35% of white girls had reached menarche. And again, if earlier age at menarche is associated with heart disease risk, this is of concern. So if moving down or moving across the life course, we move into pregnancy, you can think about pregnancy complications such as preterm birth, where there's about a 50% increased risk of preterm birth among Black individuals, and also an increased risk among American Indian and Alaska Native individuals compared to other individuals. And also, it's worth noting that in looking at other complications, such as preeclampsia, here I'm showing you on the right-hand side of your screen the rate per 1,000 deliveries, and a much higher rate among Black individuals compared to other groups for many of these cardiovascular-related risk factors that occur during pregnancy. It's worth noting that in studies such as a study that was done both in Nurses Health Study 2 and in the Black Women's Health Study, that we saw an increased risk of cardiovascular disease following a pregnancy complicated by preterm birth. And then there's been, many studies that have shown this increased risk with respect to preeclampsia and other pregnancy complications. But even as you're moving further out to midlife and you're thinking about age at menopause, you see that there's differences with respect to the onset of age at menopause, with Hispanic individuals having an earlier onset at menopause, but that from data from the SWAN study, you see that with respect to severity of symptoms such as, for example, hot flashes, that both African American and Hispanic individuals have a much are more likely to report having experienced hot flashes or night sweats. And so when you're thinking about this, it's worth noting that just kind of across the life course, there are indeed racial ethnic disparities. And I've chosen to focus in, again, in the context of health equity, there are many different social determinants that I could have focused on. I'm focusing in on race ethnicity as an example of a health equity issue here. And so in my work, I really try to understand why these disparities exist, because I'm very interested in identifying or thinking about solutions. And so in order to do that, I don't want to just kind of stay fixed in, okay, we see these disparities and that's the end of the story. And I'll show you in a few minutes with respect to environmental exposures that we see disparities in environmental exposures and that's the end of the story. It certainly is not. And so what can we kind of do or think about as far as the interconnectedness between what is driving both the differences that we see in health outcomes, but also what is driving in the differences that we see in environmental exposures. And so in thinking about this, I'm showing you kind of what we in our lab we call the translational epidemiologic approach. And it's really thinking about the upstream factors that many of you all ask questions about, what are the policies or laws in place and how can we improve those? And so certainly there's implications for that, but also thinking about the downstream factors and where we might be able to not only intervene at the policy level, but also at other levels within this. And so in the lighter yellow, these are just examples of some of the different things that fall within each of these bits. So you could think, for example, about the impact of, say, for example, historic redlining, and then how that has downstream impacted wealth accumulation by race, ethnicity, and also impacted the communities in which individuals live. And so what is available within those communities with respect to access to safer products? I think oftentimes we like to put the onus on the individual, but the truth is that what's available to folks is also quite problematic. And, going back to the point about manufacturers, but also retailers and what retailers make available. And then how that might downstream impact disparities that we see in endocrine disrupting chemicals with impact then subsequently on health disparities. So that when you're thinking about this across the life course, what you become aware of is that there are many more impediments or risk factors that including, but not environmental endocrine disrupting chemicals, but also the sources of those chemicals that could really impact certain populations much more greatly with limited measure to protect themselves from these harmful chemicals. And that across the life course, perhaps due to things like weathering, for example, or perhaps due to the fact that in general, you just have these cumulative risks, that could really impact someone's health and really grow this disparity. Okay, so getting to endocrine disrupting chemicals. If you're attending this conference, you probably already know this, but I do want to bring your attention to the two classes of chemicals that I'm going to focus in on today. So I'm going to talk a bit about plasticizers and a bit about surfactants. So I'll specifically in the context of plasticizers be talking about phthalates, and in the context of surfactants, I will be talking about per and polyfluoroalkyl substances or PFAS chemicals. Okay, so I'm going to give you two examples. In the first example, I'm going to focus in on phthalates and cardiovascular disease risk. So phthalates are found in a variety of consumer products. They're non-persistent chemicals, so can be metabolized in a matter of hours. And when looking at data from the National Health and Nutrition Examination Survey, it's worth noting in the context of even, again, what our last speaker spoke to, is that there is indeed a gender issue with women having much higher concentrations than men for many of these chemicals. And these are the metabolites that we measure as opposed to the parent compounds. And so what I will also note is that you see higher concentrations of those metabolites that are from parent compounds commonly used in personal care products. On the figure on the right-hand side, I'm showing you this by race ethnicity as well. And you do see kind of a mirroring of this with, again, higher concentrations of these metabolites for those that are more commonly found in personal care products. For example, MEP, or monoethyl phthalate, is a metabolite of diethyl phthalate, which is commonly utilized in fragranced products. So again, here, African-American and Mexican-American individuals, based on a nationally representative sample of the U.S. population have much higher concentrations. Just recently, we've been taking a look at differences across time, and we see and note that not only do we continue to see these differences, both by gender and by race ethnicity, but that it's growing over time. So even with kind of awareness and changes that are occurring, that this is widening. So in the context of a cardiovascular disease-related risk factor, looking specifically at pregnancy, and in this case, preterm birth, these are data from a pooled analysis that was conducted by Barrett Welch and Kelly Ferguson and others as an analysis looking at over 6,000 pregnancies and evaluating the association between urinary phthalate metabolite concentrations and preterm birth risk. And what I'm showing you here is that we do see an increased risk for the what is kind of boxed in orange and red with respect to these associations. So monoisobutyl phthalate, again, commonly used in a variety of consumer products, as are these other metabolites that are found. So again, I like to ask the question why. So we see this association between phthalates and preterm birth, but when you're talking about health equity, the goal should always be solution. So we're really, if we see that, you know, and I've shown you that there are differences in the environmental chemical exposures with respect to race ethnicity, we see differences in preterm birth status with respect to race ethnicity. Why is there, like, what's driving the differences, for example, in exposure, and how might that be interconnected to health outcomes? And so I think that what's, you know, here what we've done is we're using data from the Environmental Reproductive Glucose Outcome Study, or the ERGO study. And what I'm showing you is individuals who used different types of personal care products. Again, these are often sources of phthalates. So users compared to non-users. And what you're seeing, for example, is that, as an example, the hair oil use is for people who used hair oils, their concentrations of monoethyl phthalate, or again, this fragrance-associated phthalate metabolite, are 125% higher if they used this compared to those who did not use this. And we also see this for the sum. So thinking about mixtures, we see about an 80% higher concentration of phthalate mixtures from personal care product associated phthalate metabolites compared to folks who did not use hair oils. We see something somewhat similar for nail polish users. We know that butyl phthalates are commonly used in nail polish. So we see, for example, a higher concentration of some of the butyl phthalates if you are using compared to not using these products. And it's also worth noting that there are replacement chemicals that we also see higher concentrations of. So these chemicals that are being increasingly used, and these are the metabolites of them in products. And so that's of concern as we're thinking about, you know, what's circulating through folks' bodies. And the ERGO study is looking specifically in pregnancy. So this is among a pregnant population of individuals. Okay, so how is that possible? Are there differences with respect to who's using products versus who's not using products? And so here I'm just showing you data from the Greater New York Hair Products Study, where you see differences, for example, in hair oil use with African Americans and African Caribbeans using many more hair products or types of hair products compared to other groups of individuals. Okay, so going back to that question about, you know, mixtures and you know, the relevance of mixtures, it's worth noting that we found that hair products were associated with changes in hormone receptors. And one of the questions that we have is there an association between hair product use and preterm birth? Because that, while I can't, you know, necessarily know exactly how to tweak particular phthalate metabolite concentration. If I want to design an intervention for solution purposes, I want to know whether or not, suggesting that someone reduce their hair oil use, for example, if that would have some sort of impact on preterm birth or gestational age. And so what I'm showing you again is data from the Ergo study, a pregnant population where we asked about hair product use across time. And we also asked about the frequency of the product use across time. So daily versus less than daily versus never. And we looked at early pregnancy, mid-pregnancy, kind of early second trimester, later in second trimester, and then closer to delivery in third trimester. And what we found was that later pregnancy use of hair oils was associated with an 8-day earlier delivery. And that, again, if there's something that we could say, if you'll note that the less than daily use was not associated with that strong of an association. So even if what we were able to do is design an intervention or recommend to obstetricians that, if we confirm these findings, that, maybe suggesting not using hair oils, which are heavily fragrant. So, contain these phthalates, particularly the fragrance diethyl phthalate associated phthalates. So if we were to say, use these products less frequently to a pregnant individual, that may actually have important impact on preterm birth risk, and then again, later life risk of potentially of cardiovascular disease. And I think it's worth taking a look and seeing down the line, designing studies to look at this. I also just want to draw your attention to other outcomes. So we also looked at the association in the same study population of hair product use and birth weight. And the blue represents non-users of hair oils. The red dashed line represents less than daily users, and the green dashed line represents daily users. And what you'll note is that in the tails have grown and thickened, and also there's a shift in the median value for sex-specific birth weight per gestational age Z-score. And so this is saying that folks who were daily users have an increased risk of having infants that have lower birth weight. In fact, it's a 300-gram lower birth weight for daily users of hair oils compared to non-users. So again, thinking about yet another risk factor that occurs earlier in life. Okay, so I'm going to wrap this up with another example. This one is going to come from work that we've been doing looking at per and polyfluoroalkyl substances, or PFAS chemicals, and cardiovascular disease risk. And again, in the context of race ethnicity, some years ago, folks would often say there's no racial ethnic differences with respect to PFAS chemicals. That's not true. It's very much place dependent. So for example, I'm here in the Boston area. So if you're looking at your screen on the far right-hand side, you see that Black individuals have much higher concentrations of PFOS, one of these PFAS chemicals, compared to white individuals. And you see something similar in Southeast Michigan, for example. And so there's this variability. And PFAS chemicals are coming from a variety of different consumer products. They're used for their various purposes, for their anti-grease and other attributes. And so they can contaminate our waterways. They're found in our consumer products. And there's also risk from occupational exposures. And so when we're looking at PFAS mixtures, these are data from Project Viva, a cohort based here in the Boston area of over about 2,000 individuals. This is a subset of that population. And what we found is that PFAS mixtures were associated with a 40% increased odds of gestational hypertension, a cardiovascular disease risk factor. And so when we're thinking about this, one thing worth noting is that we did not necessarily see an association with preeclampsia. And we've been thinking a lot about, what are some of the differences, particularly with relation to cardiovascular disease, that gestational hypertension may tell us versus what preeclampsia may tell us about that risk. But I also wanted to start thinking beyond and thinking, oftentimes folks hyper-focus in on pregnancy and don't think about the transition that is necessary to return to a non-pregnancy state during the postpartum period. And yet that time period, otherwise known as a metabolic reset, is essential to really being able to understand whether or not an individual is going to be at increased risk for cardiovascular disease. One issue with metabolic reset is that an individual will return to kind of their normal non-pregnancy weight. And so the question of whether or not there's elevations in postpartum weight retention in some individuals and whether or not endocrine disrupting chemicals contribute to that is of importance. So here, again, looking at Project Viva, and these are individuals where we measured their PFAS concentrations in pregnancy, and then we're looking at, a time point in pregnancy, then at 1 year postpartum, and then at 3 years postpartum. And we did indeed see that there was an association with pregnancy measured PFAS concentrations, these persistent chemicals, and then 1 and 3 year measurements of increased weight retention, suggesting that, again, in the context of thinking about increased risk of cardiovascular disease, if you're retaining more weight, you're more likely to be overweight or obese, which could increase the risk of cardiovascular disease. So really, again, thinking about the goal of, in the context of health equity and environmental justice, of identifying solutions, we really need to identify potentially modifiable risk factors. And in order to do that, we should think about the role of environmental racism as it relates to structural factors and making sure that access is available to individuals for safer products. And that when we are aware of differences in place-based factors, such as chemical exposures to PFAS, that we make it available to clean up and do what we need to do to reduce the exposure to endocrine disrupting chemicals, with subsequent reductions, hopefully, in risk associated with this across the life course that could impact cardiovascular disease risk. I think some considerations that we may want to give is the importance of thinking about solutions in the context of the ways that we measure our data. So improving our exposure assessment and really trying to get at the why, starting to include the sources of the exposure and thinking about place-based factors as we're considering this, and considering the full arc of all the folks from policy to the manufacturers to the retailers and so on, not just taking or giving the burden to the individual. So really expanding our toolkit and not just kind of in the context of, I'm an epidemiologist, we just completed a review of environmental justice research where the vast majority was fixed on just using a single statistical method, effect measure modification, which simply documents difference. And so really moving into the space of, once we've seen repeatedly that there's documented difference, that we actually move into a space where maybe we utilize mixed methods, including qualitative research more in our work. And we really think about the design and role of interventions as mentioned in the previous talk. And then the role of implementation science and effectiveness research so that we understand how well our interventions are working and what we can do about them, and partnering with communities, doing more community engaged research, and really involving investigators across many other fields. In the context of health equity, we really need to involve sociologists and other qualitative scientists in this work so that we can move from a model that looks like this across the life course to a model that looks like this. So I'll just take a moment to thank my research team and all of our funders, and I can take any questions.
Thank you, Dr. James Todd. We're now going to play the recorded remarks from Ms. Tanya Lane. Thank you.
Hello, everyone. Hope you are doing well today and enjoying the conference so far. My name is Tanya Lane. I am a cosmetic chemist, and today I will be sharing hair care and the endocrine system and what you need to know. But first, let's start off with a little introduction. As I mentioned, my name is Tanya Lane. I'm a cosmetic chemist specializing in natural hair care, and I'm the creator of a platform called Curly Chemistry, where I teach consumers how to understand their hair, ingredients, and products from a cosmetic chemist perspective. And I also help entrepreneurs start hair care lines as well. And today I want to share a little bit about the science of our hair, how it relates to the endocrine system, and a few other tips as well. First, let's start off with the science of our hair. Now, as many of you know, our hair consists of three main layers: the cuticle, the cortex, and the medulla. Now, the cuticle is the protecting layer of our hair. This is the layer where the majority of our products are coming into contact with. And then you have the cortex that makes up the integrity and the strength of our hair. And then you have the medulla, which makes up the center core of our hair. Now, in this presentation, I want to focus mainly on the hair growth cycle because it's the endocrine system that determines our hair growth cycle. Now, in our hair growth cycle, you have the anagen phase, the catagen phase, and the telogen phase. Now, the anagen phase is the active growth cycle. This is where our hair is actually growing out of our scalp. This can take between 4 to 6 years, and for some people, it can go up to 8 years. And then you have the catagen phase, which is the resting phase. This is when our hair has stopped growing and it's literally resting in the follicle before it goes into the telogen phase, also known as the shedding phase. And quick fun fact, about 10% of our hair currently on our scalp is in the telogen phase. Now, when it comes to the structure of our hair, there is the dermal papilla. Now, the dermal papilla is a network of epithelial cells that contain different hormonal receptors. And since we're on the topic of hormones, let's talk a little bit about the endocrine system. Now, the endocrine system is the network of glands that produce hormones within our body. And these hormones help to regulate our food cravings, bone health, growth, sleep, reproduction, and also hair growth. Now, I just mentioned how the dermal papilla contains different hormonal receptors. Now, there are different hormones that regulate hair growth, like estrogen and melatonin, that bind to these receptors, giving us hair growth. However, on the flip side, you have hormones that are related to hair loss and different androgens like DHT, and also the stress hormone cortisol that actually binds the receptor, leading to excessive thinning and hair loss. Now, in a sense, this is actually normal because as we get older, our hormones are going to fluctuate, leading to things like thinning of the hair. However, it gets a little tricky when we deal with endocrine disruptors. Now, endocrine disruptors are chemicals that can disrupt our hormonal system, resulting in various health issues. And some common sources are cosmetics, beverage packaging like plastic bottles, food, pesticides, and toys. Now, these disruptors actually have the possibility of creating different hair growth disorders. For example, premature hair loss in women who are in their 20s or in their 30s, follicle shrinkage, and this is when the follicle shrinks within the scalp, leading to excessive hair loss and thinning. And then there's also hirsutism, and this is a condition where women will experience hair growth on their chest, their back, and also their face as well. Now, let's talk about some solutions on how we can reduce our risk when it comes to these endocrine disruptors. So when it comes to hair care, you can always opt for natural hair care formulations and even look for plant-based surfactants such as cocoa glucoside, sucrose cocoate, and decoglucoside, just to name a few. You can also do some home improvements and even install a water filter or a shower filter to reduce your risk. You can also upgrade your diet, consume more fresh and organic foods, minimize processed and fried foods, and also change out your food storage. So instead of plastic, opt for glass. Now, since we are on the topic of hair care, I would be remiss if I did not share my favorite hair care tips with you. Now, since we are in the middle of the summertime, my first recommendation for you all is to avoid sun damage. Now, the sun is amazing. However, on our hair, sometimes it can cause some serious damage when it comes to dryness, dullness, and even frizziness. So I recommend adding a little bit of olive oil almond oil, and maybe even a little bit of avocado oil on the length of your hair to help protect against sun damage. I also recommend doing some deep conditioners once a month. Depending on your hair type, you may need to do more or less, but deep conditioning is a great way to repair and protect the hair, especially in the summertime. I also recommend avoiding excessive heat. Heat in moderation is completely fine, but too much heat can lead to damage and breakage. But if you are going to use heat, always use a heat protectant. And then last but not least, at least on an annual basis, please get some blood work done and look at your iron levels, your vitamin D levels, and your thyroid levels. Any deficiencies in this area can lead to dry hair, thinning, and hair loss. Now I want to share a few frequently asked questions I get as the cosmetic chemist. So the first question is, how should we read hair care ingredient labels? Now, when you are in the store and you're looking at different products, you're going to see the ingredient list on the back of the bottle. So when you're looking at that list, the ingredients towards the top of the list are the most abundant in the formulation. Hence the reason why when you pick up a shampoo or a conditioner, the first ingredient more than likely is going to be water. And that's because in those formulas, approximately 50 to 60% and sometimes more of that formula will be water. And then towards the end of that ingredient list will be the ingredients that are in there at the least. And that'll be like your fragrances and your preservatives. Now, the next question I get asked pretty often is, do hair care ingredients absorb into our bloodstream? So the short answer is no. And that's because the cosmetic ingredients that we use in hair care products are relatively large on a molecular scale. So it'll take a lot for these ingredients to get past the epidermis, the dermis, and then into our bloodstream. And the beautiful thing about our skin is that it is a great protective barrier, especially against toxins and other foreign ingredients. Now, the next question I get asked pretty often is, how can we know if a product is compatible with our hair type? Now, I know there's a popular saying, our hair is dead. However, I truly believe that our hair communicates to us. So for example, if you are using a conditioner and you notice that the conditioner is making your hair kind of dry and frizzy and not really manageable, that's a good sign that it is not compatible with your hair. On the flip side, if you're using a conditioner and you notice that your hair is more moisturized and it looks really good and it's more manageable and it's softer, that's a good sign that it is indeed compatible with your hair. In conclusion, I hope you enjoyed my presentation on hair care and the endocrine system. If you would like to contact me, feel free to email me at ilearn@curlychemistry.com. And for additional information on Curly Chemistry, check out curlychemistry.com. Thank you so much for your attention and enjoy the rest of the conference.
Thank you, Dr. James Todd and Ms. Lane, for your presentation. We do have questions and we've got time, it looks like, for one question before we begin our next poster session. Looking at phthalates in preterm birth, I believe this question is for Dr. James Todd. Why is BMI considered as one of the point of measures when such scaling has been determined to be effective for only 40 to 50% of the world population? And what is an adjustment that can give greater accuracy?
So we've looked, I presented some data here, again, could not be as comprehensive as I would like. We actually, in the same study population, have been looking at other measures, including weight alone, and then using measures such as waist circumference and DEXA measures, such as truncal fat and body fat. We do see similar associations when looking at these other obesity measures. So I agree with you. There's no perfect measure, but there are other measures that we can use, and we have done so. Thank you for asking them.
Thank you. The next question, again, I believe is for Dr. James Todd. And this was a question about one of the slides that you presented, and it had to do with why Mexican Americans were used in comparison to, yes, why were Mexican Americans used as a comparison group rather than Hispanics at large or another Hispanic group? Are Mexican Americans at higher risk than other Hispanic groups?
Yeah, that's a great question. It actually has to do with the way that the data set is structured in NHANES. So in NHANES, particularly in the years that we were looking at in the context of this study, they selected the largest Hispanic population to oversample. So Mexican Americans are the largest Hispanic population here in the United States. And so that is why that looks that way. But it's due to the way that certainly the other Hispanics, and it's aggregated, doesn't account for the heterogeneity within the Hispanic population, unfortunately. It wasn't until I believe 2013, 2014 that, for example, Asian individuals were disaggregated from the other categories. So that's also why that particular racial group is not represented there.
Thank you. Again, thank you to both of our presenters, Dr. Tamara James Todd and Tanya Lane. I will now turn it over.
At this time, we will transition to a short break and resume the Symposium and GatherTown platform for our virtual poster session at 11:30. Instructions to join GatherTown can be found on the Symposium website, in the Zoom chat, and linked in the HHS live stream site. A link to the website and a direct link to GatherTown are now available in the Zoom chat. If you are joining us on Zoom, we strongly recommend you keep your Zoom webinar open during the GatherTown portions of the event to provide a smooth transition when we return to Zoom. GatherTown is a virtual environment, and we encourage you to engage with your colleagues much like you would at an in-person event. The functionality of GatherTown is very user-friendly. Please make sure to use your camera and microphone, and to enable your microphone access that are enabled, and you can use your arrow keys to move around the space. When you click the link to enter GatherTown, if you move your character using your up arrow, you will see the poster hall and networking rooms. If you navigate down, you will see a help desk if you have any questions. Feel free to explore the environment. There are couches, tables, and benches available for networking as well. You may also refer to the event website, which provides further instructions and screenshots for easy navigation. Feel free to join GatherTown at this time to set up your character and ensure your camera and microphone are enabled. We encourage you to use some of the break time to familiarize yourself with the GatherTown environment. When you enter the virtual poster hall, there is a directory available to easily find our many scholars. If you have any questions, please navigate to the GatherTown help desk or find one of our staff members. The virtual poster session will begin at 11:30.
Produced by the U.S. Department of Health and Human Services.